Today we're going to be talking about the renal system, so still talking about the kidneys. We've already kind of discussed filtration, so we're going to move on to reabsorption, secretion, excretion, and get into some of the details of those little things that happen kind of along the way to becoming urine, which is our goal. All right, or to go back to the blood. Um, so after filtration, which is where we are now, and we move into the renal tubule. So we start talking in terms like filtrates. We're calling it filtrate. We're talking about it being in the tubule or the lumen of the tubule. Lumen is just like when you have, a hollow thing like a tube, then the lumen is the inside of the tube. So that's what we're talking about. So the filtrate is moving into the lumen of the nephron. So contents of filtrate move into that proximal tubule. So that's the first part, proximal to the Bowman's capsule. Proximal, and then distal is over here, and then you've got the loop of Henle. So what's moving through or what's going to go away? Well, the things going into it are water, of course, glucose, so these are all things that made it through the glomerulus, urea, which is a breakdown product of proteins. We're going to talk a lot about that. Ions, sodium, chloride, potassium, those ions that we've been talking about, amino acids, a lot of waste products, phosphates, just all kinds of stuff are moving through into the tubule. The only thing really that shouldn't be there is anything that's too large, like red blood cells, proteins, and then there are some things that have charges that won't let them through. But really, it's the filtrate or the glomerulus is very forgiving and just kind of lets everything go in. Now the problem is, or the advantage is, that once something moves into the tubule, its next stop is excretion as urine. So unless it's reabsorbed. So I mentioned this before, but I think of the way the kidney filters things as if you're cleaning your room and you just take everything out of your room and then you just bring stuff back in that you want to keep. So that's what happens in the tubule, is that everything is in there. All the good stuff, all the junk, everything is in the tubule. And then we just say, okay, yeah, we need chlorides, we'll bring that back. Potassium, we'll bring that back. Sodium, bring that back. But then anything that's waste or that the body doesn't even recognize, that just leaves as urine. Okay. All right, so the division of labor. So different things happen in different places, and I can say right now that most of this reabsorption takes place in the proximal tubule. So when we have like 180 liters that move through your kidneys every day and only 1 to 2 liters make it out as actual urine, that means a lot of reabsorption takes place. So most things, just sweepingly, most things are reabsorbed. And most of that happens, 80% of that happens in the proximal tubule. So it's all brought back into the body like it never happened. Okay, so reabsorption by the proximal tubule and Henle's loop also, and that's the first part. So you've got the proximal tubule and then the loop of Henle. So most of that happens in the proximal tubule and the loop of Henle. Okay. So that's most of reclamation of water and most of the solutes or reabsorption of those things. So the distal segments, the distal tubule and the collecting ducts. So the distal tubule is kind of over here in this area, and then the collecting ducts is what kind of comes down. A lot of nephrons kind of contribute to that. But that's where kind of the fine tuning happens. So if you want to concentrate the urine, if you need to remove more solutes, that kind of thing, that happens in the distal tubule and the collecting ducts. So we call that, or I call that, just fine tuning what you're trying to filter or keep or excrete or reclaim, reabsorb. All right, so sodium balance. We have to talk about sodium balance because sodium is the king when it comes to kidney function and just lots of things all through the body. So we are a salt water. We contain salt water, a lot of sodium chloride, but sodium is really the leader of a lot of activity that happens in the kidney and elsewhere. So it's the major cation in the extracellular environment. So it has the highest concentration outside the cell. Of course, there's a lot of potassium inside cells. But in that extracellular environment, and that kind of kind of decides or regulates how much fluid volume we have in our blood and in the extracellular fluid, how much fluid we have in our body. We know that if we intake more sodium, then we have to have water around that sodium. So the kidney's ability to kind of manage that sodium is how it manages the fluid volume. Okay, so the extracellular fluid volume affects the plasma volume, which of course is your blood pressure. So all of that is kind of regulated by how much sodium we have in our body. So 2/3 of sodium reabsorption happens in the proximal tubule, so that kind of tracks with what we've been talking about. 25% is reabsorbed in the thick ascending limb, so over here, that's where we have some pretty powerful diuretics that function, is in that ascending limb of the loop of Henle. We call them loop diuretics. And that's kind of what's controlled as sodium, chloride, potassium, those kinds of things. And we'll discuss that. So the mechanics of reabsorption in the early proximal tubule. So we'll say right now we have an arrow pointing to it. This is kind of leading the show. This is the sodium-potassium pump, the one we all know, the one that's famous, the sodium-potassium ATPase. And it is actively, it's burning ATP to actively move sodium out of the cell. Okay, so it's moving out on the blood side, so this is back to the body. So it is pumping sodium back in. It's reabsorbing sodium actively. It's pulling that out. Now, we know that what happens is that we have a sodium gradient. So we have a lot of sodium out here and not very much sodium inside the cell, okay? Which means that, and the cell is, of course, if we recall, it's negatively charged inside. So sodium has to be pumped out, and it really wants to get back in. So that what we learned previously is still true. And so by sodium being pumped out, what it does is it creates that electrochemical gradient, and so sodium is trying to move in. Okay, so sodium can't move through the membrane, okay, freely. So even though it's here, it's moving from the tubule. So this is your tubule or your filtrate. Okay, that's kind of moving through this area. And sodium, again, is in the filtrate, and it's trying to move through, but it can't, because it can't move through freely because it's a charged molecule. And this is still a plasma membrane. It's still got the phospholipid membrane. Won't let it through. Then you have to have carriers, and so we use that concentration, that electrochemical gradient, because remember it's still negative there, positive here. We still use that gradient to pull the sodium into the cell, but we pull other things with it. Okay, so in this case, we can see that sodium is going into the cell, and it's in co-transport with glucose. So the sodium, secondary active transport, is pulling glucose in, it's pulling amino acids in, phosphates in, lactate, citrate, and here you have countertransport with hydrogen. So yes, it's pulling, it's saying hydrogen. No, sodium can come in, but in this case, it's pushing hydrogen out. So now it's something we're going to remember, because getting rid of hydrogen is a very, very important process. Hydrogen is kind of it's kind of, we can call it a waste product. We know that we need hydrogen for a lot of processes, but it's a byproduct of the breakdown of proteins, of other molecules in the body. And what hydrogen does is it changes the pH, so it makes things more acidic. So your body's kind of constantly fighting that, constantly saying, okay, too much hydrogen. Okay, so we need to get rid of it. So in this case, we early on have sodium kind of pushing that hydrogen out. And then once everything's in there, so we've loaded our cell with glucose here. Remember, this is the cell lining the nephron. So we're still in the kidney. We're still reabsorbing things. We're still in the proximal tubule. So we've pulled a lot of this glucose in. I'm using that as an example, but it's the same for all of these except hydrogen. So now we've got this concentration of glucose inside the cell. Well, now we just can let it out. So now we can just have kind of passive transport through. We just need a carrier to allow that glucose to go down its concentration gradient. and out. And once it's out here in the extracellular fluid, then that can be taken up by blood cells, so blood vessels. So you've got what's called the vasorecta, or the peritubular capillaries. That doesn't show this in the picture, but they're right out here. So then that glucose can just kind of move right into those capillaries too. And the sodium can move back in, amino acids can move in, all that stuff it just kind of moves right through this extracellular fluid and then into the peritubular capillaries, or the vasorecta, the straight ones. Okay, so those are going kind of the opposite direction. And that is going to matter later too. All right. Which is going to be up in this case. All right. So now we have things being brought in. Oh yeah, we're in the proximal tubule. Still trying not to get lost here. So we have one other thing down here. We have bicarbonate. So we don't see a lot of chloride moving yet. It's not that important that's taking place, but there is kind of a if you look, most of these are positively charged. Not all of them necessarily, but we do have bicarbonate. Now we're going to learn later that does not start with a G. So we're going to learn later that bicarb is actually being produced in the cell, and so it's trying to get out, and it's able to go down. We have a negative charge inside here. Okay, so it's able to, it's going to go down. It's kind of electrochemical gradient too, and it's also going to pass and come back into the body. So we can already kind of see, this is foreshadowing for acid base. We can already see that we're dumping hydrogen and we're reclaiming bicarbonate, and that's really the theme when it comes to those two ions, the hydrogen ion, the proton, and bicarbonate. Okay. So we have this note here: early loss of HCO3 tends to leave the chloride in the tubule until the later part of the proximal convoluted tubule. It's just a thing that happens. So we're going to see later that the chloride is going to leave too. Okay, so water moves by osmosis because solutes are moving. If we remember that we had kind of built up a lot of proteins in here during filtration. Remember, through the glomerulus, we were kind of letting a lot of fluid move through the glomerulus. Okay, and we were letting a lot of ions move through, but we were holding those proteins back, and so because we were losing all that water, the protein concentration kind of got pretty high in here, which is going to be oncotic pressure in these capillaries. So that too is going to start pulling water in. So water is also moving, okay? And we'll see that. All right, so this is our movement of water. So pretty much, so water moves by osmosis, okay? Obviously, because, and we just saw all the solutes are kind of bailing. They're all taken off, led by that sodium-potassium ATPase, so the sodium-potassium pump. And so all the solutes are leaving, and we just mentioned that we have a lot of proteins in here because those are kind of left over from filtration because they didn't get to go with everybody else. Well, now the proteins are just like, haha, and you'd be back. You'd be sorry. You almost became urine. But they're happy because they're happy to see them back, I'm pretty sure. Okay, so sodium leaves the cell, water follows to maintain its osmolarity. So this is the movement of water. So water can move through the cell and back into the blood, or it can actually move out down between the cells and move back this way. Either way, we have the movement of water. So they've traced this and they found that actually quite a bit of water moves out between the cells down here as well. Okay, so yeah, we have sodium leaving the cell, water following, sodium actively pumped out of the cell and into the peritubular environment. Water follows. That high oncotic pressure of the peritubular capillaries favors that absorption of water, and because we had that buildup of proteins. So chloride. So we have to mention the chloride. Your book separates them. I'm not too worried about the separation, but somebody spent a lot of time trying to figure out this process. And and what happens? So sodium and chloride are transported from the lumen of the nephron by different mechanisms. So here we have hydrogen once again leaving this environment, and then sodium, because it's a low concentration, sodium moving in. But then we have chloride that's also coming back. It's negatively charged. Remember, it's negatively charged inside the cell. So formate is another negatively charged molecule that is leaving, and it is exchanging with chloride. Now, once chloride is inside the cell, it is allowed to leave. And if we recall the equilibrium of chloride, the electrical equilibrium of chloride is around -70. So chloride will, if you give it a path to leave, it's going to leave, just because of the negative charge inside. Okay. All right. Let's see. And then sodium and chloride are also able to kind of move between these tight junctions. So the tight junction is actually permeable to small ions, and it's also permeable to water. Okay, so it's kind of letting those things back in. All right, and formate is just a waste molecule. And if we didn't know it was a waste molecule, then we know it because it's being excreted, because we're putting it into the lumen of the tubule, and it's going to become urine. Okay, or it's going to be part of the urine. All right, so glucose. We need to talk about glucose. Now, one thing we know about in general, we haven't really talked about digestion yet and absorption yet, but pretty much all the glucose that you put into your body, take it in orally as food, and what is made in the body, your body keeps it. Okay, so your body treats glucose like gold, if you're into gold, and it doesn't really let it out of the body. It's the energy source. It's what the mitochondria uses to make ATP. It's very important. So we want to bring it back in. So normally nearly 100% of glucose is reabsorbed. I will say that we don't necessarily, we have aisles and aisles in the grocery store with a lot of sugar in it, not necessarily glucose, but other types of sugar. So our bodies are not aware of that, so they still try to maintain a lot of sugar. Keep that glucose in there. All right, so glucose transporters, because I guess kind of dovetails there, because so glucose is a six-sided sugar, and when there's so much glucose, turn it into circles, that the transporter, so this is our transporter, remember sodium is going in and it's carrying glucose with it. If that gets saturated, then we have glucose that leaves as urine. Okay. All right. Sorry, I paused because I almost sneezed. Okay, so glucose transporters can get saturated, so glucose remains in the tubule and therefore the urine, and then of course water is trying to leave, but when it sees all of these guys, it's like, okay, well, not so fast. Maybe I'll just leave with the glucose and hang out there. So that's just a simple sort of osmotic issue, is that if you have more particles, you're going to, the water is always trying to maintain that osmotic equilibrium inside and outside cells, or in this case, inside the lumen of the nephron. So if there's more, there are more particles in here, then the water is going to stay in too. So you have increased urine volume, and you have glucose in the urine. All right, so let's see. So this is kind of a blow up of the same thing. It's just a part of what we already looked at: sodium potassium pump, pumping that sodium out. Sodium being used, the concentration gradient, secondary active transport to pull that glucose through, and then the glucose just sort of being released. So that's what we're seeing here. So that should be familiar. But then we have this graph down here that kind of shows what we were talking about with the saturation of the transporters. Okay, so the glucose concentration, which saturation fully occurs. So here we have, if we look at just this dotted line, okay, so we can kind of imagine it goes down here, and then it's like, so what's happening is that we have more glucose being excreted if there is more glucose. So a normal level of glucose is around 100, maybe 90 to 110, I don't know, somewhere in that area. But we get kind of concerned when it's over like 150 and 200. That's kind of not so good. So, and we can kind of see that here. It gets up to a concentration, so plasma glucose, up to a concentration of about 200. And suddenly, we can't reabsorb it anymore. And when it gets up to around 400, there is no reabsorption. That's it. I mean, we've saturated our transporters. They're working as hard as they can. They're all working. And so what tends to happen is this graph kind of points out something else. I don't know if it's necessary to point out, but it points it out, and it says that, okay, reabsorption fully occurs like right here. Okay, so that's when we have fully saturated. So that's our max reabsorption, is right about there. But we can see that it starts to get saturated, starts to slow down right about here. Okay, so that looks like about, I don't know, 230, 250, whatever. So that's when it starts to slow down. But we can see at that point too that when it starts to slow down, that we start to see glucose in the urine. Okay, and then at some point it's just like, okay, the more glucose, the more excretion, because we've saturated. These guys are working as hard as they can, and they're not gonna take on any more. They're not going to reabsorb any more glucose. They're maxed out. So then at that point, it looks like at about right here, a little over 400. Okay, well, that says right there. But either way, around 400, a little over. That's it. That's the max. And then any more sugar that's going through there is just going to be more and more that's excreted. Okay, so they have these little areas called splay. Not too worried about it, but that's just showing that it's not, hey, everything's working fine, we're doing great, and then boom, we hit a point and it's like, okay, we're saturated. It's saying things are actually slowing down before we hit that saturation point, which means that we start to see glucose in the urine before we hit that saturation point, because the saturation point's right about there. Okay, but we start to see it in the urine right about here. All right, so let's see, glucose concentration, which saturation fully occurs, and at which transporters reach threshold. Let's see, glucose begins to show up in the urine. This is all stuff I just said. Begins to show up in the urine due to gradual slowing of reabsorption prior to complete transporter saturation. That's what we were calling splay, these areas that are kind of colored in. Not too concerned about that because it kind of makes sense. Remember also that if glucose remains in the tubule, more water will also remain in the tubule. Can't forget about that due to those oncotic forces of the particle glucose holding on to that water. So glucose in the urine is associated with increased urine volume. So when we think of diabetes, there are a lot of symptoms that could possibly happen with diabetes, especially a new diagnosis. But a lot of times, honestly, people start noticing that they're peeing all the time. And, especially with type 2 diabetes and older people, they're running to the bathroom all the time. And they have a fair amount of volume. It's not like they're just peeing a little bit. They have a fair amount of volume, and then they're thirsty because they're losing a lot of water that way. And then you get checked, and your glucose level is 500 or 600 or higher, and then then it's off to the endocrinologist. All right. So loop of Henle, so that's our next step. So we made it through the proximal tubule. We've reabsorbed about 80% of the stuff, and now we're at the loop of Henle. So we're going to do so things get a little trickier in the loop of Henle. Okay, so as we move down, so we moved out of the proximal tubule, the proximal convoluted tubule. As we move down here, we get to this point where the loop of Henle says, okay, all those particles that we were pumping out, we're going to stop pumping those out. Okay, so some of them can leave. They can leave if the concentration gradient says they can, but we're not going to pump them out anymore. So now any kind of movement of particles is kind of minimized because it's passive movement. However, water is freely permeable, and water is going to move out. So we have to kind of do this one thing at a time, but we happen to know that down here at the base of the loop of Henle, we have a high concentration of solutes. So it's very thick down here with particles, urea, everything is kind of down in this area. And then as we get up here, it's a little more dilute. Okay. All right. So that means that as the water moves down, it sees these particles and it's like, oh, I want, some of that. I want to move out to where these particles are. And so it just keeps moving more and more and more water from the tubules until we have, and so that's kind of why it's a thin limb, the thin descending limb, because that water is it's being pulled out by all these particles. And that concentration gradient, because up here it's about 300, which is normal, and down here it's 1200. So just by opening this up to water, a lot of that water is going to move out. Now the particles can move out too, and they do. But you can see the concentration is already pretty high in this area, so they're less inclined to do that. So since they're not being pumped out, you have less movement, and it's mostly just water moving out here. All right. Okay, so then we get, so the descending loop, let's kind of read through this, contains the water channels, those aquaporins. So there's some permeability to small ions and urea, especially down low. Okay. Urea is kind of does all of its stuff down in this area. We're going to talk about urea. Increasing osmolarity deeper into the medulla squeezes or pulls that water out of the tubule, so we're really trying to get that water out. And it's going to, of course, move back into circulation because we have capillaries that are kind of running along there. So water is building up outside the nephron in this area. So, but the concentration is high, so it's kind of diluting the that concentration, all that water moving out. But we're going to see why that doesn't stay diluted. It's because that water is going to be pulled back up again. All right, so now we're down here, and we're kind of passing around the corner, and now we're in the thin ascending limb. Okay, so we're in this part here, the thin ascending limb. So now we're shutting off the faucet. So we're saying, all right, water, you've had your fun, you've been pulled out, now you are stuck in here. So water is staying in the loop of Henle, and it can't leave anymore. Okay? So that permeability to water is no longer. So the water is just going to kind of stay up in here. All right, so solutes are passively reabsorbed here, but no water, so that means that solutes are building up outside the nephron in this area. So our particles can kind of move out, but not the water. And that's just in that early part. Well, then we get into this thick ascending limb, and then we start really pulling solutes out. So we've got sodium is being pulled out, chloride, potassium, even things like calcium, phosphates are being pulled out. All of these ions are kind of moving out of this area, and sure, why not? All we have to do is give them a chance to move out, because again, the concentration up high is pretty low. Okay, it's not thick and murky like it was down here, and so there's one transporter. So there are a lot of transporters that allow a lot of ions to move through. There's one in particular that's really important to this process, and that is the sodium potassium chloride cotransporter. So that's going to take a sodium and two chlorides and a potassium, and it's going to move those out. Okay. Now the reason that's important is because it is, first of all, it's the major transporter that's getting most of those ions out. Okay. And the other thing is that we have furosemide or Lasix, which can block this. So So we really, that's why we talk about it, that's why we care about it. But really, if we're just looking at kidney function, normally, it's a way to get a lot of ions out of there. And when we're getting ions out, but that water has to stay in, what do you think is happening to the concentration of water? The water is just like, hey, where's everybody going? All the ions are leaving. Okay? And as it happens, then we end up here once we get up to the top. So we have the thick, so it's the thicker limb again. You can see that if I delete that arrow. So this is thicker because you've got a higher water concentration, if you could say that, but you have fewer solutes. You still, of course, have solutes, a lot of solutes, but the concentration is like down to like 100, okay, which is even lower than normal. So we've really pulled those solutes out, okay. So we have this gradient now of 100 here at the top, which is very low, even lower than normal, which is around 300. And it's very concentrated down here at the bottom. So that's what happened in the thick ascending limb. So can make up for decreased reabsorption in the proximal tubule. Now, I'm reading this bullet here without reading the one that introduces it. But so sodium, so we have to make the point that, remember, most things left in that proximal tubule. Okay, so most things are gone, including most of your sodium. Now, and so now we're seeing that that sodium and, in this case, potassium. Remember, potassium was being dumped. Potassium is being reabsorbed here, and that's kind of an important point. So I know I'm trying to say two different things at once right here. But we had sodium being pulled out. But remember, when we were pulling sodium out, we were kind of pushing potassium back in. Now, some of that potassium was able to leach back into the body, but a lot of it was left in this tubule. So this NKCC, the sodium potassium chloride cotransporter, is allowing some of that potassium to finally leave and come back into the body. And because we need potassium, we need our potassium homeostasis is as important as any other ion. In fact, more important for especially like cardiac function and cell function or neuron function, muscles. So sodium is being pulled out, potassium is being pulled out, and we can't forget about, even though we do a lot, we can't forget about chloride. Okay, so sodium is actively removed from the tubule. Okay, in a concentration-dependent manner, so more sodium means more reabsorption. So what that means is that, and this is what I started to say earlier, is that the sodium is being removed here, and then it comes over here, and it's like, okay, now more sodium is being pulled out. And the more sodium there is, so let's say that there's a lot of sodium in the body, so the more sodium that there is that wasn't pulled out through the proximal tubule now makes its way through the loop of Henle, and it's like, aha, okay, there's still sodium in there. So now we start pulling it out even more. So by concentration dependent, that means that the more sodium there was in there, the more is going to be reabsorbed, okay, back into the body. So that can make up for decreased reabsorption in the proximal tubule, or just a lot of sodium. Proximal tube diuretics have a limited function due to this. There aren't a lot of proximal tubule diuretics, but there are some, and they're not going to have as much of an effect, just because if they block sodium from being reabsorbed, it doesn't matter because it'll just be reabsorbed here. Now, you can use them with other things that block this. So if we block our NKCC, or sodium potassium chloride cotransporter, then those ions will continue in the tubule. So the sodium, potassium, and chloride will continue in the tubule, and they'll pull water with it, and they will leave as urine. Okay? And a whole lot of water. And that's why it works as a diuretic. So if we block this, and we say, no, you guys, all of you ions, you're going to stay in there, and all that water is also going to stay in there, and it's going to leave as urine. Now, you can probably guess that it's called Lasix or furosemide. Bumetanide does the same thing. So these, you can guess that these are going to have an effect on potassium, because here, that's what I was saying earlier, is that potassium, remember, potassium is going the opposite way as sodium. So when we're reclaiming sodium, we're kind of putting that potassium into the tubule. So when we start pulling potassium out, saying, hey, we need potassium, then we have this issue. If we block that and we give furosemide, that potassium levels are going to fall, and they do, and we monitor that, and the patients are supposed to eat a high potassium diet, or they may take potassium pills. You know, it's something that we're aware of. All right, so that got us through the loop of Henle, and so now we get to move into, nope, I forgot, we have to talk about that concentration gradient. That's very important in the loop of Henle. So we're going to wait to go to the distal tubule until we explain that concentration gradient. Okay, so we have vessels. We've mentioned these before. Vessels that go, capillaries, that go along and are outside of the tubules. We call them paratubular capillaries, but there are some specialized capillaries that have been found, and it's like, okay, they're straight and they just go straight down with the loop of Henle, and then they go straight back up. They're not, you know, all twisty around like we see with paratubular capillaries. I don't know what kind of organization they have, but these are the vasa recta, recta meaning straight. So all of these things that were happening. Remember when we said at the descending limb of the loop of Henle that water was allowed to move out, and you know, some smaller particles, but really not actively pumped out. So this is mainly just water moving out. And we said that the concentration down here was very high concentration, so 1200. So that's your milliosmolar. That means that a high number means that it's very I want to say dirty, murky, thick, you know, but it's got a lot of particles in it at 1200. Okay? Water loves it. Water wants to go out where all those particles are, and that's what pulls the water out. So remember that. But the trouble is we have a lot of water trying to dilute that. So it seems like after a while, this water would actually cause, all this water moving out would cause it to be very dilute over here, like, you know. We won't give it a number, but we'll just say that it's going to be less than 1200 or whatever because of all the water moving out. But, so pause on that. And then we see on the other side, kind of the opposite is happening. All of these salts are moving out. So we have sodium chloride, potassium, but we also have, you know, magnesium, calcium. A lot of other ions are also moving out in this area. And so we're like, well, why isn't the concentration like really high over here and really low over here where there's a lot of water? And that's because it's because of this vasa recta. It's because of this capillary here. Because as soon as these particles move out and they say, oh, look, the concentration, let's see, we're kind of up close to the top, so we may say the concentration here is 300. Well, they're like, oh, well, we'll do that. We'll go into where it's 300. We were less inclined to go out down here where it was 600, you know, but some did if the concentration's high enough. But then as we lose more and more and more, then it just kind of keeps getting pulled out until we're down here at 100. Okay, so what does that mean? Well, it means that, I don't know that it means anything except that the concentration is getting lower and lower, but they're still moving out, and then as soon as they move out, they get pushed into the paratubular capillary and then pulled down. Okay. So what that's doing is it's saying that solutes will move in, but the concentration is just building up more and more because all those salts that have been moving in are just being kind of flushed down to the bottom. Okay? So that's why we end up with that 1200, because these salts that are like, oh, it's only 300, we're going to move out, and then it's a trick, and it moves into the capillary, and they say, haha, you're going to go down to here, and now it's going to be thick and murky and 1200 milliosmolar per liter, milliosmoles per liter, milliosmolar, and that's where kind of the particles settle in, And so we have this thicker area because we have all these particles that are going to move in. So they're like, oh, we like the lower concentration up here, but then they get pulled down, they move around, and then the water's over here saying, oh, look how thick and murky it is. We like that. And so the water starts moving out, but it's also a trick. And the water is then taken back up here to where the concentration is lower. So the water's like, oh, look how thick and murky it is. Love it. But then it's pulled in and it's like, oh, okay, we're going back up. All right, back up here to where it's 300. So that just continuously happens as things move through. And it's because the filtrate is moving in this direction, okay, around this way, and the vasa recta, these vessels, the flow is moving in the opposite direction. So this is saying, here you go, here are some ions, and that's saying, oh, thank you for those ions. We're just going to drop them right down here at the bottom. Okay. All right, so that's what we call the countercurrent mechanism. So we have a few slides talking about that. Okay. So water leaving the descending loop causes the nephron concentration to get higher. Solutes leaving the ascending loop causes the nephron concentration to get lower. All right, and then we, I jumped ahead of myself. I always do. I need to rearrange my slides probably if I keep doing that. This is a slide looking at the sodium potassium chloride co-transporter. So we've already mentioned this. Furosemide is a diuretic that blocks it. So if we block this, then we have we don't have reabsorption of sodium, we don't have reabsorption of chloride, and we don't have reabsorption of potassium. Okay. Okay, so it's just kind of showing what happens with these ions. Sodium is transported in, okay, down its concentration gradient, pulls that chloride and potassium with it, and then we have sodium actively removed from the cell. Potassium, some of the potassium gets reclaimed, okay, which is good. But a lot of this potassium that's being pulled in will then just kind of move back in. Okay. And Lasix is the name of the drug. It blocks this transporter. You should know how it works. At high doses, it can completely block sodium chloride reabsorption, causing excretion of nearly 25%. Okay. Which is a lot. It's not 100% reabsorption of sodium chloride, but 25% just added to it by this is a lot, and that's going to be a lot of water that's also pulled with it. All right, so back to maintaining that concentration gradient that I kind of have already explained. So we'll kind of go through this a little more quickly. So water moves out if there's a higher concentration of solutes, so we see that. We've got this murky area down here, so I'll just kind of quickly explain the same thing that I just did. And then the water is going to see that it's going to move out, but then it's going to be passed back up through with this vasa recta. So solutes are constantly being replenished. That's what this is saying here in the capillaries, because of the not just the NKCC, but just ions moving out, seeing that lower solute concentration as it gets higher, so they just kind of keep moving out, but then they're pulled back down. Okay. So it just kind of flips the whole thing 45 degrees. It just kind of keeps this moving down, keeps the particles moving down, and the water moving up. Okay. All right. So maintaining that concentration gradient, that is called the countercurrent mechanism. So the different permeabilities of the loop of Henle. So this is kind of a summary of what's happening. So filtrate in the nephron tubule and the blood in the surrounding vasa recta capillaries are flowing in opposite directions. So remember that. That's an important feature of this. The different permeabilities of the loop. So remember, this is permeable. The descending loop is permeable to water. The ascending loop is permeable to particles. Leads to a top to bottom concentration gradient, so water moves up and solutes move down. Okay. Simplified version, water leaving the descending loop enters the vasa recta and is brought up. Salts and solutes leaving the ascending loop enter the vasa recta and are brought down. Okay. So a couple of more images showing the same stuff happening. Okay, just different ways of looking at the same thing. This one has the vasa recta on the inside, so don't mix that up. but we see the same thing. The salts are moving out of the tubule, say, and look at that, it's only 300, they're swept in and then brought down. Okay, so we have this continuous increase in concentration. Same with water. Water's like, oh look, it's so thick and dense down here, but then it's immediately, it's like, nope, you're going back up. Okay, and it takes it back up. All right. So removing ions from filtrate makes the filtrate very dilute, but increases interstitial and capillary osmolarity. Water moves to an area of higher osmolarity, solutes move to lower. All right, and then we have again another shot of the sodium-potassium chloride cotransporter, actively removing sodium and chloride from that ascending loop. And then we have one more, I think. Yeah, this is just from the Costanza book, showing the same stuff that we had just talked about. Water kind of moving in and out down its concentration gradient. Okay, so let's talk about what happens in the distal convoluted tubule. So activity there, distal convoluted tubule and the collecting duct, they kind of merge a little bit. So some books I've noticed says that they'll say that things happen in the convoluted or the collecting duct, and other books will say it happens in the distal tubule. So it kind of can happen in both. Is kind of the conclusion I've drawn from that. So let's kind of like look at this. We have a sodium-potassium pump here. So sodium can be actively transported out of the tubules into the interstitial fluid by inserting more sodium-potassium pumps. So it's not just sodium-potassium pumps. There are other transporters that are also kind of put in there. But that's the job of aldosterone. So remember aldosterone, and earlier we were just saying, oh, aldosterone increases the reabsorption of sodium. And we were all like, oh, we're happy with that. Well, now we're kind of looking at the process or the mechanism by which that works, and it's kind of the insertion of these sodium-potassium pumps. Okay. So actively transporting sodium out then, and that's what we're doing, is we're pulling that sodium back out of the tubule, all right, reclaiming it, and of course in the process we're putting potassium in. So some of that potassium will be reclaimed, and actually some secretion of potassium, if it's low, can kind of, or if your potassium levels are high, can also cause loss of even more potassium, but in that case it's okay. And we're really at an equilibrium. So when things are healthy, this is the way it's supposed to work. It's not like we're always low on potassium, because this is the way it's supposed to work. But it can be a problem with diuretics. That's why we keep saying it over and over. All right, so actively transporting sodium out can reduce that blood potassium, and it can be a problem with those diuretics. So the distal tubule, so this is the role of aldosterone. So we can't forget about aldosterone yet. So that is something that, you know, we still have to know. We still have to remember that, even though we covered it in the last section, the previous section too. It is definitely a kidney function, so we have to know it for this section. But yeah, that's the active transport of sodium out of the cell, and that is going to increase your blood pressure by pulling that sodium out, reabsorbing sodium. So the distal tubule and collecting ducts have variable permeability to water. So we also have to remember that ADH, antidiuretic hormone, also known as vasopressin, is also an important hormone, and it puts in water pores and allows water to be reabsorbed. Okay, so do we remember that? That was also in the last section, but it's a kidney function, so same thing as aldosterone, have to know it. And that's kind of how adjustments are made. So vasopressin is released. So something else we talked about before, I don't know if anybody remembers, but we're measuring the osmolarity of the blood. So we have, so that's something that kind of happens with in the hypothalamus. Okay, so that's one of those things that's kind of directed from the hypothalamus to the pituitary, and it says, okay, well, if the blood is more dilute, blood volume is higher, well, then we won't insert ADH, but if we say, okay, this person is, the sodium concentrations are high, the blood volume is low, so osmolarity is up a little bit, we need to reclaim more water. Okay, so if that decision, quote unquote, is made, then we have that release of ADH from the posterior pituitary, and then it will go and it will cause that insertion of water pores, okay, and allow water to be reabsorbed. Okay, so that's how that works. And of course, we're going to talk about ADH one more time when we talk about hormones. And you guys are going to know it really super well. All right, so depending on what happens, remember when we were kind of looking at concentrations, and we see that the concentration can get really low. It can even get down as low as 50. Okay, so that's because we have more salts being pulled out, you know. And so if we say, all right, no aldosterone, I'm sorry, no ADH, not worried about aldosterone, so aldosterone's pulling that sodium out, and we have a concentration of 50, or milliosmolar is 50, so that's just like basically water. And we're saying, nope, no water can be reabsorbed, so water has to stay in here. Then we are going to have high volume, low concentrations. We're going to be in this situation, a high volume of low concentrated urine. So this is going to be clear, and it's going to be a lot of it. Okay. So, and then we say, nope, we are going to reabsorb more water. We are, let's say that we are dehydrated, and we're like, then the pituitary says, nope, insert water pores, lots of water pores, aquaporins, the fancy name for those. And so then we have water being reabsorbed. Then the water is going to be reabsorbed up until that concentration. So as long as there are particles out there and you're saying, hey, water, you can leave, it's going to leave into that until the concentrations are similar. And so then we have, if we have the aquaporins present, we have a low volume of highly concentrated urine. Okay, so that's kind of cool how it can just kind of be controlled just by controlling the movement of water. Okay, and that's the role of ADH. All right, so let's see. So let's kind of back up and talk about some of the, drill down into some of the details of the distal tubule. So about 80%, so this is sodium handling and chloride. So about 8% of sodium is reabsorbed in the distal tubule and collecting ducts, about 5% in the early distal tubule. So not too worried about the percentages. Basically, that's just saying that, that we still have a lot of sodium particles, ions, that can still be reabsorbed. Okay, so it's reabsorbed with the NCC, the sodium chloride cotransporter. Okay, so that's chloride in this case. All right. So the reason we're talking about this, and we have a special slide for it in this particular mechanism, is because thiazide diuretics can block this NCC. So the sodium chloride cotransporter, remember sodium's trying to get into the cell and it's pulling chloride with it. Now, it blocks it, or it shows the effect here on the chloride binding side, which is true, but it shuts down the whole thing. Okay, so if chloride can't bind, then the whole thing just doesn't work. So what you end up with is sodium and chloride left in the cell, or in the filtrate, and then it becomes urine. All right, and it's going to be a high volume of urine, because it's going to bring the water with it. Okay, just like in any diuretics, you reclaim or you excrete the particles, the water will follow. All right, so we can kind of look at this mechanism. It's sodium potassium pump, pretty typical there. Secondary active, sodium's going down its concentration gradient, pulling chloride with it, and then we can just open up the channel for chloride, and chloride will go back into the body. That's the way it works. If we block it, none of that happens, or it happens at much lower rate, and we have increased urine. Okay, so let's see. The degree of sodium reabsorption varies with concentration. Okay, so that's one of those kind of local automatic regulatory mechanisms. So thiazide diuretics, hydrochlorothiazide is an example of that, or chlorothiazide, I don't know. Hydrochlorothiazide is a diuretic that has its effect there, and they block that NCC, the sodium chloride cotransporter. Okay, actively transporting sodium out can reduce potassium levels again. So we're still talking about potassium. Okay, and the fact that diuretics are not always good with potassium, but we're going to address that here. Okay. Okay, because I just circled potassium-sparing diuretics. We have some of those. Spironolactone. All right, so activity at the late DCT and collecting duct. So again, we're still in the distal tubule, and we're talking about this because, again, we have another site of diuretic activity. Okay, so the sodium-potassium ATPase results in sodium leaving the cell. There's our mechanism. And then we have a lone sodium channel, okay, that allows sodium to move back in. Now, the good thing about this is that when we shut it down, okay, so this is going to, you're causing the reabsorption of sodium, which the reabsorption of sodium is linked to potassium leaving. And of course that's going to increase your water. Okay, so that's why or let's see, if we're reabsorbing, I'm trying to talk about both the diuretic function and the actual function. The actual function is that this all works, and sodium is reabsorbed, and then it is moved back into the body, and then potassium is dumped into the tubule, and you lose the potassium. Okay, so potassium then leaves as urine. Okay, so that's kind of this function of this. All right, this is why it's a handy thing to have as a diuretic, because you're pumping potassium in, and then potassium is actually leaving. So if we block this, hopefully we already see where this is going, and they've already put the lines through it for us. If we block this sodium from moving in, then what happens is the sodium stays here and we lose less potassium. Okay, so we maintain the potassium levels because that electrochemical gradient isn't off, okay, by the sodium moving in. If the sodium is moving in, then it's going to boot some potassium out. So if we don't do that, then we don't boot the potassium out, and we spare potassium. Okay, and that's important. So so aldosterone works on these. Okay, hold on. So potassium secretion occurs through potassium channels. Selective sodium channel, as opposed to cotransport that's usually seen, allows sodium reabsorption into the cell. So aldosterone works on these kinds of cells. They're called principal cells. And increases the number of these selective sodium channels, as well as the sodium-potassium ATPases. So remember I said that earlier when we were talking about how aldosterone has its effect, and we said, well, aldosterone increases the sodium-potassium ATPases, but it also can increase these sodium channels. Okay, so if we block spironolactone, spironolactone is a potassium-sparing diuretic that blocks the action of the aldosterone on these cells. Okay, so that's what it's doing. It's preventing that sodium from being reabsorbed, and now we're losing sodium and not potassium. So this note here is actually kind of important, even though it's the smallest font on the page. The effect of potassium-sparing diuretics is minimal because so little reabsorption happens in the late distal tubule. But they are useful if they're used with other diuretics. So if you're taking another diuretic that causes dumping of potassium and you're losing a lot of potassium, then you can take the spironolactone, you can take this potassium-sparing diuretic as well, and then you don't have that as much of a loss of potassium. It kind of conserves that potassium. Okay. All right, so maintaining potassium balance. Since we're on the subject of potassium, there is some secretion of potassium that can take place. So 98% of potassium in the body is found in cells. We know that. It's important for cardiac muscle function, and so potassium is tightly regulated. It's important for cardiac... Oh, I already said that. The kidneys are largely responsible for potassium balance. Intake must match excretion. So that's the case with everything, right? I mean, we can't just eat a bunch of salt and then it all collects in our body, and we have to excrete what we take in, or we're going to have a lot of problems. So it's true with potassium. And so we have to have some control over it, because we don't just always eat the same amount of sodium and the same amount of potassium and all that stuff every day all the time. So we have to have mechanisms in place to say, oh, they ate a lot of bananas, so we have to excrete more potassium. Or there aren't any eating any bananas. We need to conserve potassium. All right, so let's see. So potassium, this is the same kind of nephron we've been looking at with some of the other ions. So about 2/3 of potassium is in the proximal tubule, about 20% in the ascending loop. Okay, so we know that, and that's part of the NKCC, so that's the K in the ascending limb. Well, then if we don't have much potassium in the blood, we have more reabsorption of potassium here in the distal tubule, and then in the later distal tubule or collecting duct, then we actually have secretion. Okay. So if we have high dietary potassium, okay, and remember aldosterone. So we just saw that in the previous slide, that the activity of aldosterone is to put in more of those sodium transporters, which is going to move potassium back into the urine. Okay? So remember, secretion is going to lead to excretion. Okay? Secretion is from the blood back into the tubule. Okay? So this is all happening. And then acid-base, so we have some co-transport or transport with hydrogen. Yeah, and then flow rate, luminal ions. I'm not sure what we're getting into there. Okay, all right. So the point is that we can control potassium, either reabsorption or secretion of potassium, to keep its levels regulated. All right, so let's see. Details here. Reabsorption happens through a type of cell called intercalated cells in late distal tubule. Okay, so this is reabsorption of potassium in this case. So we can see sodium potassium pump, hydrogen being pumped out, and then I guess it's counter transport. Potassium is being pulled in and hydrogen is being left out. So this is potassium reabsorption. So those are the mechanisms that we were just talking about. Okay. Okay. So this counter transport with hydrogen, okay, and then potassium is being reclaimed, reabsorbed. Secretion, same thing, sodium potassium pump, but in this case we're just saying, hey, okay, potassium, you can just go. And that is what we saw earlier with, this is where aldosterone has its effect. Okay. All right. Okay, let's see, because aldosterone works on that type of cell, the principal cells. All right, so secretion happens through reabsorption happens through these, what they call alpha intercalated cells. Happens through a type of cell that in the late distal tubule, potassium is removed from the filtrate by the hydrogen-potassium exchanger. Here, potassium then diffuses back into the body. Okay. Okay. And this is a contributor to blood pH as well, okay. Because we're still dumping hydrogen. All right, secretion through the principal cells. Secretion is determined by the size of the electrochemical gradient, which is determined by blood potassium levels. So let's think about what that means. So if we have a lot of potassium, remember potassium is positively charged, and potassium kind of builds up inside the cell, then we'll have more potassium that's lost. Okay? However, if we have low potassium and our potassium levels are minimal, then we have less potassium that's lost. So it's kind of a local automatic kind of a control mechanism. So let's read that. So in other words, if potassium is low, the membrane potential is more negative. Okay, because remember, potassium is positively charged. Okay, so if we have less of it, then we have a more negative, hyperpolarized. So we remember that from the neuro section. Okay. So potassium will be less inclined to be secreted out of the cell. So it's less secretion. When potassium levels are high, it's going to remove some of those negative charges, and so it's going to be more positively charged. Well, if that's the case, then potassium is definitely going to be excreted. Okay. Secreted and excreted. All right. So other factors that affect potassium, cell lysis. So let's talk about some of these because they're kind of interesting and important. So cell lysis, remember, and it doesn't really have everything to do with the kidneys, these don't, but they are still important. They have to be talked about. Remember, we have a lot of potassium inside cells. If something happens to break the cell, then that potassium goes outside the cell. And now we are in, if this happens in high numbers, a lot of cells are broken down, then we end up with hyperkalemia, which is increased potassium in the blood, emia, blood. All right, so so we can see that the example I put here is chemotherapy with tumor lysis syndrome, but it can also be from any kind of necrosis that happens in the body. If you have infarction and you have a lot of wounds, injuries, crushing, you know, if you lose blood flow to an area and cells just start to die and lyse and break. That's why, if you remember apoptosis, that's why apoptosis is a good thing, because the alternative is just for cells to kind of break. And then you have that release of potassium and all kinds of other stuff. So cell lysis could increase potassium levels in the blood. Insulin, now insulin this is kind of an important one too, functionally and medically. So insulin increases the sodium potassium ATPase activity in certain cells. So let's think about what happens when you eat those bananas. You eat 20 bananas, and even though, you know, they aren't the highest in potassium, we associate bananas with potassium, and they do have a lot of potassium. So you're eating 20 of them for whatever reason. Maybe it's all you have in the house. Well, that's going to be a lot of potassium, and you're eating them all at once or in a short period of time. So your potassium levels are really going to get high as that stuff is absorbed into your body. Well, you have a mechanism in place to prevent your potassium levels from getting so high that you just caused your heart to go crazy and die. So, and what it is that insulin is released when we eat. We have an increase in insulin release, and it will cause potassium to move into cells where insulin is active, which are muscle cells, liver cells, fat cells. Okay, so it'll allow potassium to move into those cells, which gets it out of the extracellular fluid, which prevents a lot of the problems. Okay. All right, so the shift allows rapid storage of dietary potassium in cells and prevents hyperkalemia when you eat. Okay, so consider what happens to someone with untreated type 1 diabetes. Well, remember, with type 1 diabetes, the pancreas is unable to produce insulin. So normally the pancreas produces insulin, but it's not able to. It is not functioning. Okay, and so no insulin means that when you eat those bananas, you're not going to be able to quickly store that, and so they would have hyperkalemia. Okay, so that's what we would expect. All right, so other examples, beta-2 agonists, those also shift potassium into cells. Alpha adrenergic agonists shift potassium out of cells. So we can kind of see that with adverse effects or side effects of medications. So consider the effects of beta blockers. If you block beta-2 agonists and if you block beta-2 receptors and activation of those is shifting potassium into the cells, it's going to leave potassium out of the cells. And so propranolol, it's a LOL drug, it's an LOL drug, which means it's a beta blocker, may cause hyperkalemia. Okay, just because it's not shifting, it's letting that potassium be outside the cells. All right, and then we saw some exchange with hydrogen before, and that's kind of what we're looking at here. Hydrogen and potassium secreted into the filtrate in the distal tubule, and sodium and potassium move by active transport across the basal membrane, okay, which we kind of see here. So just a reminder that secretion of hydrogen and potassium, we kind of saw that slide earlier that showed that. All right, so urea. We need to talk about urea, and then we'll talk about a few other kind of random things that kind of have a overall role in kidney function. All right, so urea is a breakdown product of proteins. So it's secreted or absorbed by diffusion. It's either simple diffusion or facilitated diffusion. And so what happens is, if we look at this with kind of the way we've been looking at everything else, with these other, like with ions, we see that it's a little bit different. The handling of urea is different than it is with like sodium, potassium, those ions. So we don't want urea necessarily. It's harmless. It doesn't really hurt anything, but it's also a way for us to get rid of proteins that are broken down. So we do kind of want urea to be passed in the urine. So in a normal day, 100%, so 100% filtration, so that means there's nothing limiting it from filtering. It's not stuck to proteins or anything like that. And then about half of it is immediately reabsorbed in the proximal tubule. Okay. And so the rest of it kind of moves down into the loop of Henle, and then we see some secretion that happens down here. So the thing to pay attention to is that movement of urea is really kind of down deeper in the medulla. Okay, so the secretion is happening here in the loop, and we see reabsorption that's happening down here lower in the collecting duct. Okay, so the proximal tubule 50%, descending loop, there's some secretion, collecting duct, there's reabsorption, and it's a maybe kind of a thing. It's variable, but on average we have 50% is reabsorbed, and then we have so much secretion. I feel like that arrow should be bigger, because down here it's showing that after the loss of water, so we have urea moving in, but we also have water moving out. So now we have this really highly concentrated amount of urea. So now we have 110% urea down in the I guess the bottom of the loop of Henle, and so that's kind of what we have. So 100% was filtered, 50% less left, and then it looks like we put in about 60% more, so we actually have more than we started with. And so we have that 110% here, okay, and now we get to this situation where water is leaving, but we don't have permeability to urea. So the urea really gets to be a high concentration, okay, because this is water moving out of the collecting ducts. Presumably, if we have ADH having its effect, and I'm going to show this again, in a couple of slides. Okay. And so then down here, it's like, okay, we have a high concentration of urea. And then it's like, okay, so now in the presence of ADH, that urea is able to move out. So we put in urea transport proteins, and we're allowing the urea to move back out. So let's think about that. Okay, so we had it moved in over here. That's fine. And now we're saying, okay, urea, there's a lot of water moving out into this area, because that's what ADH does, is it lets the water go out. And it's like, well, but you know what? We don't really want to dilute this area. We like it being very, very murky and gross and concentrated down there. So it's like, okay, urea, why don't you go out there and cause and keep that very murky and gross. Okay, by murky I mean high osmolarity. Okay, lots of particles in there. So the milliosmolarity is osmoles per liter is high. Okay, that's what murky means. It doesn't really. All right, so so that's kind of what's happening. Is if ADH is present and it says, all right, we're letting water go out, then it's like, well, we kind of have to set that offset that, otherwise we're going to dilute this area and we want it to be highly concentrated, so it lets the urea go too. All right, and we'll say that again and with another picture. So urea also contributes to the high medullary solute concentration. So remember, lower concentration at the top or at the outer areas, and then very concentrated down here. And we can kind of see that. I like this picture because it kind of shows what's going on. It's saying, all right, urea can only be left out if it's down in this lower area. Okay, it's not allowed to come out up here at the top. Okay, it's not coming out of the proximal tubule like everything else does. It kind of moves on through. Well, no, it does actually. Sorry, yeah, 50% of it does. But then it's secreted back in here, and then it kind of just stays down in this lower area. All right, so yeah, it travels through there, and it's like, okay, you can go out down here, and then it's secreted back in, and so it kind of just works in this area, and it keeps this area concentrated down here. Okay, so we have less concentration up here. All right, racy. All right. So let's see. So descending limbs of the loop of Henle permeable to urea secretion. So it's moving in here. Ascending limbs and distal tubules are impermeable. So nope, you're not getting out there. You could just get out here if the aldosterone or the ADH says that you can. So urea flows in a cycle, maintaining a high urea concentration in the medulla, and then only about 40 to 50% is actually excreted. Okay. So same thing here, kind of pointing out what happens with the ADH. Okay. In this case, so remember we have 110% whatever that we've kept. So a lot of urea, and then we can see in one here we have permeability to ADH, antidiuretic hormone. So water is moving out. Concentration of urea is getting higher and higher. Okay. Increased tubular fluid concentration of urea due to water leaving. Okay, that's what this little thing, concentration of urea in the tubular fluid. And then it's like, okay, let's see, is it step 3? Increased water permeability due to ADH also increases the urea transporter 1. So now it's like, okay, there you go, urea, you can start to leave too. Okay, so we have water here leaving, and now we have urea, okay, that can leave. And then of course it's immediately secreted back in, and that's the cycle of urea, and that's how it helps to maintain that concentration gradient. So vasopressin, we can go through this very quickly. I feel like we needed a slide kind of repeating the function of vasopressin. So inserts the aquaporins to allow reabsorption, or there is no sodium reabsorption, so we have a large volume of dilute urine. Okay, remember, without without ADH, because this can be confusing. You can memorize it if you want to, but if you know the process, you can kind of figure it out. But with no ADH, we have large volumes of dilute urine, and I have a confession to make. I remember this because I know that alcohol blocks ADH release and binding. So it blocks ADH activity. So that's what makes you pee when you have alcohol, is because it blocks the function of ADH. So you have large volume of dilute urine when ADH is not there. Okay. All right. And usually we're somewhere in between. Let's see, ADH and urine concentration. So, yep, we saw that kind of earlier. We can have, so with a lot of ADH, then we're reabsorbing that water, which means that we have low volume, high concentration. With no ADH, it just moves straight through. Wait, with no ADH, yeah, it moves straight through, so we have very dilute, okay, low osmolarity of water. All right, so a couple of other things to talk about: GFR, creatinine, and BUN. So GFR is glomerular filtration rate. Creatinine, we already talked about urea as being a breakdown product of proteins. Creatinine is a breakdown product of a specific molecule, creatine. Okay, so creatine is a product of, or creatinine is a product of creatine breakdown that occurs in the muscle. So creatine is a molecule that kind of holds on to a phosphate group and then can transfer that to an ADP to make ATP. So it kind of, that's what creatine does in the muscle. So you find it in muscle, and then when this is used up, it is broken down, and it is broken down into a molecule that we affectionately call creatinine. Okay, so we want to name it as close to the other one as we can to make it as confusing as possible. But yeah, creatinine is a breakdown product of creatine. Occurs in a muscle, occurs at a pretty constant rate in most cases, unless you're doing something, you know, a lot of activity, an unusual amount of activity. For most people, their creatinine breakdown, or creatine breakdown into creatinine, is pretty constant. Now, we talked about inulin and how inulin is not absorbed or secreted, so the amount of inulin that is filtered is usually excreted. Okay, so this is a picture of our Bowman's capsule, and then we just went all the way through the tubule without any leaving or without any coming back, and we just excreted it as urine. Okay, now, if that little picture made any sense, just a very much a simplification of a nephron. So the deal with creatinine is that it is 100% filtered, right? It's endogenously produced, so we like that. It's freely filtered, and so if we have excretion on excretion, do I not know how to spell excretion? All right. If we have excretion on that side, then we can see that there is no reabsorption, but there is a little bit of secretion. Okay, so a little bit is added to it. So if we have 100% filtration, I don't know what the percentage is for excretion over here, but it's going to be slightly higher. So it's going to be slightly higher than 100%. Okay. So it's a little bit exaggerated, but it's not bad, and it's a good way to measure changes. So if we see that creatinine is building up and up and up in the blood, so maybe it's 1 or 2 at some point, and then we see it all the way up here at like 20 or 30. Okay, so 1 to 2, we're thinking, okay, that's not bad. And then we see it kind of going up and up and up, and then we see it at like 30. Then we can say that our kidneys are no bueno. So that is, so if we see it at those high levels, that's a very bad thing. So that's an indication of kidney, I don't want to say failure, but kidney disease. So the kidneys are failing. They're not working properly. Okay. So it's endogenously produced, fairly constant rate, freely filtered, not reabsorbed, has low secretion, secreted at low levels, which means that it slightly exaggerates the GFR, but we don't care. I mean, we can just say, okay, that's a thing that happens, so we can consider that when it's reported. But then there are other issues like heavy exercise may cause an increase in creatinine, but usually we look at trends over a certain amount of time. And yeah, if somebody, on day 5 of their hospital stay, runs a marathon up and down the halls, and we can say that's probably why the creatinine's getting high. But chances are they're going to be in their room, their creatinine is getting high because they're, because of something else. Okay, diuretics can also, a lot of times cause that, which we saw before. All right, so creatinine, good measurement of kidney function. Blood urea nitrogen, so that urea we were just talking about in the blood, when we measure it in the blood. So we know that it's also a breakdown product of proteins. It's a waste excreted in the urine. So unlike creatinine, BUN is subjective to reabsorption. So we already saw that when we saw how it's reabsorbed in the descending limb of the loop of Henle. So we say, well, that's probably not going to be a good measure for GFR. Okay. But we also know that it's about 40 to 50% excreted. So then if that changes, then that's also an indication that there's something wrong. So unlike creatinine, it's subjective to reabsorption, so not a good indicator of GFR. Because urea is made in the liver, that's something else, that the protein breakdown, enzymatic breakdown of proteins happens in the liver, and that's where urea is, actually produced. And so if you have lower urea in the body, that can indicate liver disease. High urea in the body indicates that there's something wrong with the kidneys. Now we can kind of compare urea and creatinine, and if we see like a BUN to creatinine ratio, we see the BUN is kind of increasing at a faster rate. Well, it's got some secretion going on, which kind of changes that, so we can kind of see that that's kind of an early indicator of kidney problems. Okay, so but we just need to kind of know how it works. So high protein diets and internal bleeding may also show increases in BUN. So anything that's going to cause a release of proteins and the breakdown of proteins. All right, so let's look at a couple of more things. Calcium and magnesium. So we have little charts or little figures here that kind of have been showing us our ions and how they're reabsorbed and where. So calcium differs from sodium that 40% is bound to protein. So it is not freely filtered. We keep saying this is freely filtered. It's freely filtered. Calcium is an example of something that is not freely filtered, and so so about 40% of it is tied to proteins, albumin in the blood plasma. Okay, so we can see that. Now, excretion. Let's see. Both magnesium, so we've got calcium here, we've got magnesium here. So magnesium, so we can see 67%, that's kind of in line with what we saw for sodium as kind of a metric over here. So 60% reabsorption of the calcium that does make it through is in the proximal tubule, only 30% for magnesium. And we see a lot more magnesium is reabsorbed in the ascending limb. So furosemide can block that. So we can see that furosemide has an effect on magnesium. So magnesium levels are probably something to watch. Same with calcium, but maybe not to the same degree. So both magnesium and calcium reabsorption are affected by these loop diuretics, furosemide or Lasix. And so that means that hypocalcemia and hypomagnesemia are potential side effects of Lasix. So if you don't have that reabsorption, they're lost in the urine, and that's something you can see. Okay. All right. In addition to hypokalemia, we can't forget about potassium. It's mentioned 100 times. Okay, one more thing to discuss, mannitol. So your book has something about mannitol, and I like it. Mannitol is a sugar, so 1, 2, 3, 4, 5, 6 carbon sugar. And unlike glucose, which is a ring, okay, mannitol is not a ring, and you can see it's got all these hydroxide groups out here. That it increases oncotic pressure in the blood. So because it doesn't cross membranes, it will pull water into the blood vessel. So if this is a blood vessel and we inject someone IV with mannitol, then that mannitol will stay in the blood vessels, okay, and it will pull fluid out of the interstitium, and into the vessel. So it moves that blood from the interstitium of tissues, including from around the brain. And this is a lot of times how mannitol is used, is if there's swelling in the brain, fluid collecting in the brain, then mannitol can be injected. It will move that fluid from around the brain tissue into the vessel, and then the same thing happens in the kidney. So this is why we're talking about it. In the kidney, mannitol is filtered, but again, it's not able to cross that membrane, so it is not reabsorbed. So it pulls that fluid out, it goes to the kidney, and then it just follows all the way through and is lost as urine. So it pulls fluid. I mean, if we simplify it to, I mean, it can be used for lots of things, but if we simplify it to reducing swelling in the brain, pulls fluid off the brain and dumps it out as urine. Okay, so that's kind of what's happening. So in the proximal tubule, it decreases water and sodium reabsorption, okay, because it's staying in there. And then it moves out as urine. So mannitol thereby functions as a short-term therapy, because if you give it long-term, then it will start to leach out into the interstitium. But as a short-term therapy, it works fairly well to remove excess fluid from tissues and as a diuretic to increase urine production and excretion. And that is our last slide. Oh my goodness, these are getting so long. All right, well, have a good day, night, whatever.